We are absolutely privileged, ladies and gentlemen, this afternoon to have our afternoon session kicked off with the one and only Mark Songhurst, who is a long-term supporter of the Institute. Mark, we're absolutely thrilled you can come and tell us about what you're doing up in Leeds. Just to let you all into a little secret before Mark begins, Mark is almost personally responsible for something at Leeds that I'm just astonished that it hasn't been picked up and replicated absolutely everywhere else in the country. You're about to find out what this thing is, and I'm really looking forward to Mark telling us about what it is. For everybody's benefit, Mark is the project manager for Scan4Safety at Leeds Teaching Hospitals NHS Trust, and he's going to be talking about Scan4Safety more than just a procurement exercise. Mark, we're really privileged and lucky to have you speaking to us this afternoon. Thank you. Away you go.
Excellent. Thank you, John. And I'm just a little worried after such an introduction that I've got a slight reputation to live up to now. So, hello, my name's Mark. I'm the Scan4Safety Programme Lead at Leeds Teaching Hospitals. And what I want to do over the next 45 minutes is talk you through what we've done at Leeds, how we're standardising data, and how we're improving our patient care. So I'm going to share my screen, and people should now, I hope, be able to see my screen. Fantastic. If we set the scene a little, let's go back to where healthcare really started to be documented. And this is from a book called The Propriété de Livre de Choses, which was written in the Netherlands in the 14th century. And shows emergency care 14th century style. And this slide is nicked with pride from my boss. And it shows a clinician applying the latest treatment of bloodletting, a patient coming in worried about something in a bottle, potentially urine. We then have a patient that is looking incredibly pale, clutching his chest, and probably needs to be seen very urgently, but is stuck behind two other people. We then have the walking wounded that are coming in and shouting and saying that they need to be seen. There's an awful lot of information in this one slide, and healthcare hasn't changed. We still have people coming in for the latest treatments. We still have patients coming in worried, and we still have patients coming in that need to be seen that end up in the back of the queue. And how can we start to look at this without becoming a factory, without becoming a processing plant? How do we meet the level of care that we need for our patients? So if we look at our scale at Leeds Teaching Hospitals and what we've brought in, we work across 7 hospitals across 5 sites. We are the largest provider of specialist care with 150 specialist services. Our turnover is £1.4 billion, and we have a patient responsibility of 5.4 million patients. In 2021, we saw 195,000 inpatients and 235 accident and emergency patients. So that gives you some idea of the scale at which we operate. To look after them, one of the asides that I put in, we operate 19 different menu types at Leeds Teaching Hospitals across 32 different menus. So the scale of the organisation and the challenge of putting any change in is really difficult. But when we look at our patients, our values are the same. We have a responsibility to that patient. The Trust wants to be the best for specialist and integrated care. And underpinning that, we have 5 values. So we are patient-centred, we're empowered as employees, we're accountable as employees, we try and work in a collaborative fashion, and that's really important for the way what we've done with Scan4Safety, and we're fair. And we then have a Leeds improvement method, which is basically the Toyota production system applied for healthcare. So the work that's been done at Virginia Mason, we've replicated here at Leeds. What were the national drivers for Scan4Safety? So it came from the Department of Health. And in 2014, the Department of Health launched the e-procurement strategy. And they thought, from some experiences that we'd had, that we needed to do things better. So 2011, we had the PIP breast implant scandal. And it is still worrying that there are patients out there who do not know whether they have a faulty breast implant. Luckily, most of those are within the cosmetic field, but there are still some NHS patients that this may apply to. There was also then the horse meat scandal in 2013, where we all discovered that our beef burgers weren't quite necessarily the meal that we thought they were. And the retail sector was very quick and went, we know exactly where all these products are in our shops and could take them off the shelf before anybody could buy any more. And the Department of Health thought that we needed to be able to replicate this within healthcare. So they launched the e-procurement strategy, which said, let's look at global standards for healthcare and using barcoding. So GS1 barcoding, global standards 1 barcoding, and public procurement, pan-European public procurement online, PEPOL. Now that was kind of a bit of a long title for any project, and it got nicknamed Scan4Safety. And that's what we were trying to do. Could we improve our ways of working? So we were asked as demonstrator sites to bring in 3 sets of standards. So global service relationship numbers. Can our patients be identified easily? And by identifying our patients, I am not talking that we scan a barcode and that tells us who the patient is. What we're talking about is we identify our patients by talking to them. We make sure that we have the correct wristband on a patient, and then we use the barcode from that wristband to open a series of documents or make recordings against that patient's records. We then looked at global location numbers. Could we identify the individual areas of the hospital? And when we did that at Leeds, the physical areas that our hospital had at the time was 22,303 different rooms. And we needed to be able to identify those individually, so we knew where a patient was being treated and what we're doing with that patient. And then finally, global trade item numbers. Could we start to identify the products that were available on the shelf in a standardized way? Because we all know products as different things. As you travel around the country into different organizations, forceps and different things get called different things. Bear huggers were an entire entity to me, and I went to find a pair on a shelf once and somebody said, well, they're not called bear huggers, they're called inflatable something or others. I'm just like, how do we identify this? And we used to end up in supply chain with lots of items going out to a supplier. They'd send us a product in and it'd be the wrong product because what they knew it as and what we knew it as were different things. We were then asked to put in 3 primary use cases. So could we do inventory management? Could we do a product recall that was far more effective? So when we looked at the breast implants, that took us 8 months at Leeds to go through all the registers. Let's not repeat that. Could we actually improve our product recall? And then could we use pan-European public procurement online to speed the entire process up and take the human factors out of ordering? So that allowed us to look at 4 things, and the 4 things of Scan4Safety: the patient, the place, the product, and the process. But this was suddenly became very real that this wasn't just procurement. We started off under the Director of Finance, and very sadly, he was taken ill. And our new executive sponsor was the Deputy Chief Medical Officer for Leeds. And he said, that's lovely that we're looking at product, but there's a really big challenge. For those of you in acute healthcare, if I asked you now, could you tell where every patient was in your organisation? And it is very difficult. The phone will shut up eventually, I do apologise, to tell where patients are. We needed to be able to look at different things, improve things, and be more than just procurement. So we got board level support from our directors of finance, our deputy chief medical officer, and then to our current day medical director of unplanned care and our director of finance at present. We've had the board come round and see the work that we're doing. We've presented products to them so that people can actually understand and get their hands on a product. And we've had national teams come and talk to us. But this all starts with the patient. And this is vital to everything. And as my boss said, he's not very good at spelling because healthcare begins with a P. Healthcare begins with a P because it begins with the patient. And what we've been able to do here at Leeds is standardise the data that we put on a patient wristband. So it doesn't matter whether our patients arrive as an elective patient, whether they arrive at an assessment centre referred in from a doctor, whether they are newborn and enter the world with us, or whether they're brought in as an emergency patient via ambulance. The moment that we give them the wristband, we also give them a barcode that allows us to access their records. And this means that whenever we're putting information into a patient record, we're putting it in the right patient record. So that means that a nurse on the ward is able to check that we've got the right patient and we've got the right wristband on the right patient, then scan the barcode, open up the patient record, and from there, make sure that we record things for the right patient. Simple, quick, easy. But it also means that that nurse is at the patient bedside. Our patients feel more secure because the nurse sits next to them with an iPad and fills in the documentation that needs to be completed. And we're standardizing the data. The form is standardized. The amount of information that you can put in because it's on a tablet is standardized because we can control fields and we can improve the data quality that we're getting. Our places, so we identified all of the locations, but for our Deputy Chief Medical Officer, being able to go down to the room wasn't good enough. We wanted to be able to go down to the bed space that we've got. So we have several levels of barcode. If you walk around these teaching hospitals, it's like barcode city. You cannot escape them. They're on the doors, they're on the walls. And what they do is they allow us to know which organisation a room belongs to, which site a room is on, which building, which level, and which room. And we can go back and pull that data back. We can share that data so our distributors know when they're scanning a barcode, if the barcode scans, they're in the right place. If it doesn't, they're about to try and deliver something to somewhere they shouldn't be. We're also able to use this for our patients, and I'll come on to how we've done this, but we've actually gone down and created a barcode for every bed space in the organisation. So we are able to attribute a patient to a bed space by scanning barcodes. We're also able to control our stock by using function location numbers. So whenever we move our stock around the organisation, we know where it is. And as we're all aware in healthcare, we never keep a ward in the same place. So as that ward moves around the organisation, the stock stays with that ward as a historical record. We've been able to pull our products through, and we're able to individually identify 98% of the products that we use on inventory by a single barcode scan. This means that we're not quoting manufacturers' part numbers. And for an example of that, we had at one point in our catalogue a manufacturer's part number that was the same for 3 different suppliers. So it could have bought us a sheathed catheter needle, it could have bought us a blunt fill needle, or it could have bought us a porcine heart valve. If we'd sent the wrong product number to the correct product number to the wrong supplier, we could have ended up with thousands of porcine heart valves and not thousands of blunt fill needles. So this is where it becomes important that we standardize our data and we use global trade item numbers. And if you look across the world, there is UDAMED that's trying to do this. There is the American FDA that are using the Good ID. And there are ways of uniquely identifying products. But what we ask our suppliers to do now is provide us with a global trade item number associated to each product. So when we scan that, it can link back to their catalogues and we send them clean data to say, this is exactly what we want. So we're not spending our life returning products that have been wrongly delivered. We filled this into our inventory systems, and we have an amazing team of people here at Leeds that manage inventory for us. They're on the wards, making sure that the nursing staff don't have to worry about ordering things. They just go to the drawer, open the drawer, take out what they need, close the drawer again. The next time they go back to that drawer will have been replenished if it was running empty, and they don't need to use good old-fashioned nursing just in case stocking of anything. We can then do the same for scanning products using barcodes. We do have a few RFID cabinets for high-value stock items. And then the final thing is the picture in the center is our trauma department store. That store has over 5,000 product lines in it. There are 20,000 items available at any one time. So if we didn't use barcoding, trying to find anything again would be a nightmare. And the picture on the right is our cardiac catheter labs, and it shows the challenges that we face. Our storerooms just aren't big enough for the boxes that now come in. So we're now having to expand onto the corridor, but no longer is it abandoned on a pallet. Our inventory teams have found nice, neat racking, courtesy of COVID, that was installed in the Nightingale. It's now installed in the hospital, allowing us to manage stock more efficiently. And as I said, we're able to provide clean data. So that long manual process of writing out a request form, sending it across, maybe somebody typing it into a computer, creating a purchase order, mailing that to the supplier getting back in touch with us, creating their own manual order, sending us an invoice, then potentially sending the products, us receipting things, us querying the invoice because it didn't quite match what we wanted in quantity or supply, us scanning it and then storing it on a computer has been removed. We create inventory areas where we know what stocks should be held, and that is done by the clinicians. They decide what stock is held and in what quantity. We scan the product when we use it. That then does two things. It sends an order off to the order approval system, and if it's on inventory, it's automatically approved. If it's on the general ledger, it's sent straight out of the door to the to the supplier. We're sending out the exact item that we need, the exact quantity, a price matched from their category, the exact addresses that it needs to be. That goes to the supplier, who sends us the correct goods, to the correct location with the correct quantity, and we've got the products that we need to be able to automate the process. Their invoice comes in, it matches automatically, and that process is done and dealt with. The invoice is paid. But as I said, this is more than just procurement. This is about patient safety. So here is an example of the record books that we have for theatre stores. If we have to go back and recall a product, I identified 194 books in this slide, 800 records per book, 155,000 records that you would need to go through in a product recall. In 2019, there was a product recall on breast implants because a manufacturer lost their CE marking. We have to make sure our patients are safe. At 10:15 in the morning, the MHRA confirmed that those products needed to be recalled from the shelf, and it was only a shelf level recall. At 10:28, we were able to confirm that we had those products in the trust, but that they were not going to be used that day. So we'd already spoken to theatres within 13 minutes. At 11:42, we were able to confirm to the medical director operations that those products had been removed from the clinical areas and were under the control of the inventory management teams, so wouldn't be used within a patient. At the same time, if we'd have needed to, we could have produced a list of patients who had had that device implanted. By the time this hits the news, as an organisation, we are able to say, your patient safety has been looked after. We know which patients have the affected implants, and we will be contacting you about your implant and about revising the surgery that we need to do. So product recall for the majority of implants is so much simpler. We still face challenges on consumable items, and that's because we use so many of them. They're in drawers, they're in trolleys, but we know where to start looking now so that we can actually start looking for those items. As I said, I wanted to look at the patient journey. So this is a patient journey, and I hope this is flicking through on your screens, for a patient undergoing a breast procedure. So they start off in the waiting area. We send them off to the imaging area. Once they've finished in the imaging area, they need to go to the lift, go up a floor, cross into another building, find the lifts again, go down a floor, work their way out and go to nuclear medicine. We used to lose those patients. So what ended up happening was the ward would be ringing up breast imaging saying, have they been to you already? They'd then ring nuclear medicine, have they been to you? The theatres would be ringing the ward to say, is the patient back? We have to be able to do something better than that without infringing on the patient's privacy, or without sending them with a member of staff to escort them all the way through. So what we were able to do is use the barcodes. We're able to scan the patient wristband and scan the plaque on the wall. And this shows us a patient journey. So the patient arrived in the waiting area. We checked we got the right patient and we gave them a wristband. We were able to then scan that wristband and scan them into the waiting area to say, this is where they are. At 8:30 in the morning, they went across to breast imaging, and we were able to scan their wristband and say that they were in the breast imaging outpatients area. At 9:50, they came back into the waiting area for the ward. At 10:35, we took them into an anaesthetic room. At 10:41, they were in the operating theatre. 10:32, they were in recovery. And at 14:05, this patient arrived back on the ward, having had their procedure. At each step, we knew where that patient was. We were able to then confirm to that patient relative where they were, that they were in, say, recovery, and you could start to come and join us because the patient would be back on the ward. We've talked about this with our patients, and they feel so much safer when we're doing this because people are interacting with the patient. I remember sitting as we introduced this in the breast theatres area, talking to a patient and their relatives and describing what we were doing. And somebody said, well, it's just like Amazon, isn't it? You know, you're just tracking where we are. You can look up and tell us exactly where in the process we are. And I said, I suppose, yes, it is like Amazon, but slightly more important. We're tracking something slightly more important. To which the partner of the patient replied, well, it depends what you've ordered from Amazon. I didn't get involved in that discussion. I very quickly exited, but it is the same principle. People are used to being able to see where something is. I'm going to hopefully show a video, and this should work. Are people hearing any sound? No. Okay, so I'll talk over this. So this is our electronic patient record. And what we're going to do is we're going to transfer a patient between one bed on a ward and another bed on a ward. So the first thing that we're going to do is we're going to search for our patient, and we're going to scan check the patient wristband and scan the wristband. We've now opened up that patient record. So we've now got the right patient record for this patient. What we're going to do now is update their location by clicking on the update location. And behind each bed space, we have a plaque. There we go. So we've scanned the location plaque and said, do we want to transfer? This automatically says, do we want to transfer the patient? We can now click, yes, we want to transfer the patient into the new ward. This brings up the patient details for the transfer of care. So this is the new ward, the time, and the consultants that are responsible for the patient care. We can check through and make sure this is correct. We can edit it if we need to, or we can say, click transfer. We click transfer, and hopefully at this moment in time, it's been going away. It's written all the details to the electronic whiteboard on the ward to say, here's where the patient is now, also to the patient administration system. And that is done. At that point, you can log out the system and you've transferred a patient live at the bedside with the patient there. You've not had to run back to the computer, log into a system. You can do that as part of onboarding your patient into the ward. And we're able to do that at 3 o'clock in the morning when a nurse hasn't got much time. That's allowed us to start seeing where our patients are. 24/7, we know this patient has been moved to this area. The challenge is we have so many things we could look at, and our program started to get a little burdened by the work that we were doing. So we looked at our structure, and there was an old test called the Clapham Omnibus. What would people expect somebody to be able to do? We now talk about your average shopper in Sainsbury's. So we're looking now at 3 things in Scan4Safety. A live bed state. Can we use that patient transfer information and that data to give us a live bed state to know which beds are available and which patients are where? We've got a work stream that is still about creating inventory, but it's inventory plus. It's more than just buying products. And we're also starting to look at real-time location within our emergency departments. Can we stop people having to have their names streamed throughout the halls of the emergency department? Staff running around checking 4 or 5 locations. This is a map of a patient journey through the hospital and all the interaction points. These are all the points we need to consider when we're looking at a live bed state. So where does a patient come from? When are they going to get a wristband? Which route are they going to go through the hospital? Are they going to go straight to an intensive care department? Are they going to have various procedures recorded against them? And can we improve all the data that we've got? And we're slowly unpicking this map at Leeds, but we are now able in our general medicine area to actually use a live bed state and know which beds are available. So we have a prototype that says, this is the bed that is available, and these are the beds that are unavailable and why. So some have got patients in, but we can also now code to say that that bed is awaiting cleaning. So we're able to go in and go, right, we can free up 17 beds if we just crack on with the cleaning. We're able to go with 16 beds that are lost because of infection. And because we've now got the standardized data in the background on the beds, we're able to feed that information into our infection control system. And the infection control team can also now do contact tracing because we know which patient had an infection, but we also know which were the 3 other beds that were in the bay that patient has been in contact with. So we're able to start using live bed state data to work out contact tracing of infection because it's been entered in a standardized way and we know the standardized data. we're able to start creating an integrated inventory system so that we're putting the patient back into the start of this. So we pull data from the patient administration system. So when we assign a product to a patient, we know exactly which patient. We're able to use our theatre management system, and we're just building this link in now to actually say what procedure are they having, and can we pull all that product ready for the clinicians? So actually there's a box there, it's got everything in the clinician needs. Can we then push that out into our electronic patient record so that actually we no longer have to look in an inventory system for what happened to a patient, but it's in the clinical note and we've entered it once and we've captured that data by barcode scanning once. Can we then pull that through into the costing team so that the costing team can see it? And can we finally put that into the new surgical device and implant registers, all from that one set of scans that are pulling everything through in one go, so that nursing staff are not going in going, right, let's scan this piece of information, let's now enter it into another system and then enter it into a third system and fill out a form that we're sending off to another department. We capture it once and we report on it multiple times. So the simple barcode scan of recording what we've used on a patient can be very quickly flicked around to scan a product and say, how many of these have we got in stock? Live in the clinical area. So somebody can go, actually, it's okay, I have another 10 of these on the shelf. I just maybe need to go look a little more closely. And our managers are able to see more than just an ordering system. They're able to see what we've used, where we've used it, what the value of stock is. So our finance teams can know up to the minute what stock is sat in inventory. And we can also know which items are about to expire their sterilisation. Do we need to go pull those off the shelf? Do we need to arrange for new stock to be added? We can also see, have we had to use something that's past its sterilisation? And I'm pleased to see on this report that actually our expired items issued is 0. So we've never had to use an expired item to ensure a patient's had a procedure. And finally, we're looking at our ED department. Can we track where a patient is so that we know where we've got space? We're not having to go around asking 5 or 6 areas, where's a patient? We're not got that embarrassment anymore of a patient arriving in the hospital, their relative joining them 2 hours later, and us going, where are they? I was recently in with my wife in ED, and I actually overheard a conversation with a nurse ringing a patient relative at home to say, is the patient still in the hospital with us? If we can bring real-time location in, we will know whether that patient is still in the hospital with us and know where to start looking for them. This is very much work in progress, and the big challenge we're facing, and I'm writing a paper on at the moment, is the proportionality of tracking a patient as opposed to their privacy. There is proportionality there, I just need to prove it on paper, and we will then be able to start using this, but not only for the patients, for the equipment. So actually, the drugs cupboard keys, can we remove that scream that is heard on every ward every half an hour at least of who's got the keys? We'll be able to look on the system and know exactly where the keys were. We'll be able to look on the system and know where our bladder scanners were. So where next? Well, we're using this now within...
Mark, forgive me, we are actually out of time. We've done the half hour now.
Sorry, I thought I had 45 minutes. Sorry.
It's my fault. I don't think I was quite clear enough to you when we were discussing earlier on in the week. But look, I think we've all absolutely got the gist of this, haven't we? I've got one question for you, a succinct answer, if you don't mind.
Yep.
Is this being used everywhere else in the country? And if not, why not?
It's being explored in various areas, in various bits. Hull are doing amazing work, Salisbury, North Tees, Derby. So there are pockets of this that are using it. The why not is the capital investment that we need to put the system in, because every director of finance wants it to pay within 1 year, and it doesn't. It takes 2 or 3 years to recoup the finance.
Well, it just strikes me as, I mean, this is just a no-brainer for eliminating waste and helping patients to kind of, you know, have a better experience of their time with the unit. Well, look, as I say, we're out of time. Mark, I've got to say a huge personal and on behalf of the Institute, thank you to you. I know you've had some tough times recently. We really appreciate you coming in and taking time to tell us all about Scan4Safety. Isn't he great, everybody? I bet you all wish you had a Mark Songhurst in your organisation for thoroughness and kind of dedication. I just think that's outstanding. Mark, thank you very much indeed. We're most grateful.
No problem. Thank you all, and enjoy the rest of your conference. Thank you.
Thank you, Mark.